watch at a later time. If you have any problem participating in a recorded event, educational event, please feel free to leave now. However, your remaining with us is your implied permission to be part of a recorded event. The program this evening provides 1 hour Category 1 physicians AMA CME and 1 hour of Virginia Nurses Association CE credit. Sovah Health is accredited by the Southern States CME Collaborative for Category 1 AMA CME programming. Similarly, Sovah Health is accredited through the Virginia Nurses Association to provide nursing CE credit. We developed the program this evening in order to promote patient-centered care, utilizing evidence-based medicine practices. Dr. Kapoor, myself, and members of the Sovah Health CME Committee have nothing to disclose as far as commercial relationships, and there is no commercial support for this educational activity. The program this evening, as is the case of the majority of our CME programs, is supported by an educational grant from the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. Dr. Landis, the founder of the Southside Urology Clinic, also known as the Danville Urologic Clinic, created an educational fund for broad medical education for this area. Upon his retirement, this fund has provided support not only for physicians, but also nurses, nurse practitioners, allied health professionals, EMT, and dental CME throughout this area in Danville and extending over to Martinsville for Sovah Health programs. You will receive by email an evaluation form at the end of the program or first thing in the morning. We ask that you, when you complete that you will be asked to re-enter your name and your correct email. Please put your full name in that response on the evaluation form. That you're putting it there gives us the name that should be on your CME certificate. If you're sharing a login this evening with another colleague, please let myself or Mary Kent or Vandora Holt, a nursing coordinator for the education for our market group, so we can be sure that everyone on your site is getting credit for their participation. We also have put in a QR code in the chat that'll pop up towards the end of the program. You can access the eval form there if you so wish. Otherwise, you will get one by email at the end of the program or first thing tomorrow. CME certificates for physicians are maintained through the ACCME PARS website. I think the majority of physicians participating in our programs have indicated they would participate in this system, utilizing what's known as the PARS passport. There is a box to check and information to provide if you've not given that permission to do that on the eval form, which I think most of the people, at least the ones I've seen signing on so far this evening, all are participating in that. For nurses, nurse practitioners, an eval form is required for you to receive your CME certificate, so please be aware of that. If you have any questions about the evaluation process or certificates, please feel free to contact me or Mary Kent, our CME coordinator for Physician CME, and or Vandora Holt, market director for nursing education. I always like to make a point at this time in these introductions to thank both Mary Kent and Vandora Holt for their help in developing not only this program, but all the programs we do. They really make all these things truly happen from a technical point of view and from the extensive documentation accredited programs require. I know Dr. Kapoor is anxious to have you ask questions. She welcomes your comments, concerns. We also feel the same way. When we get questions, it makes the whole evening a little more, if you will, warm and fuzzy and personable. So if you want to ask a question, you can either send it through the chat or do the little raise your hand or even just speak up. Once you've asked your question, we do ask you to mute your phone for the response It simply prevents the feedback. You are more than welcome to ask more than one question or more than one comment. So we hope you will. But again, just muting your phone just eliminates the feedback. Let me very briefly remind you of some of the upcoming CME programs that will be happening next week on February 13th, the evening before Valentine's Day, if you will. We're going to have, I think, a very special program. Dr. Reimer, who's an interventional cardiologist at Duke, was a participant in the recent American Heart Association guidelines for cardiovascular management of a patient undergoing surgery. In other words, if a patient normally has heart failure, diabetes, or in this case, cardiac issues, valvular heart disease, etc., American Heart has updated their guidelines for how that condition should be managed when they're coming into hospital or outpatient surgery for an elective procedure. So if you care for perioperative patients, just as Dr. Kapoor will be talking about anticoagulation aspects next week, Dr. Reimer will be talking about managing those type patients' cardiovascular problems before and after surgery. The week after that, February 20th, and we have a program each night for the next 4 Thursday evenings between now and the first part of March. February 20th will be a UTI stewardship presentation by Dr. Aaron Getler, a member of the Infectious Disease Division at Duke and a member of the DASON, if you will, group at Duke Infectious Disease. She'll be talking about indications and appropriate management of urinary tract infections, including for inpatients, catheter use, bladder catheters, etc., and about the appropriate duration and management from an antibiotic point of view of urinary tract infections. The final Thursday in February will be a GI talk. Dr. Kimberly Beavers, gastroenterologist here in Danville and part of the Sovah Health System, will be talking about the epidemiology, risk factors, and screening strategies for colon cancer. This was something requested in our needs assessment, as were these other topics, particularly about the current best ways to screen for colon cancer. As you may already know, it's seemingly occurring at earlier ages, and there's a greater risk. So it's important that you are able to promote that to your patients. And then the last part of our cardiology programs for this year is going to be on March 6th, where Dr. Stephen Green will review the current American Heart Guidelines for heart failure. Dr. Green's done this in the past, and he's coming back as a request because everyone enjoyed that so much to just simply do it again. And then Dr. Fadim is an advanced heart failure specialist cardiologist also at Duke, who is involved now with remote monitoring of heart failure patients, the implantation of certain devices that allows volume status to be judged once the patient's actually gone home, a whole new, if you will, cutting technology to try to help those patients not only manage their heart failure, but help prevent them from being readmitted to hospital. March 13th will be a diversity, inclusion, and equity program. We're really happy to have Dr. Tobe, who is a cardiologist and the medical director of women's heart health within the OBGYN department at Cone Health in Greensboro. And she will be talking about health equity in maternal health care. So, hope you'll be able to attend one of those upcoming programs over the next, what amounts to 6 weeks. But this evening, we're delighted to have Dr. Sargam Kapoor, hematologist from Duke, talk about managing DVT, pulmonary emboli, and perioperative chronic anticoagulation for patients. Dr. Kapoor received her medical degree from the Maulana Azad Medical College in India. She completed her internal medicine residencies at Georgetown in the MedStar Center, then did hem-onc fellowships at 2 locations, Montefiore Medical Center in New York City in the Bronx borough, and then also at the University Hospitals in Cleveland's Medical Center. She, at every level of her training, has received recognition for her excellence In her academic efforts, she was awarded the first year medical school distinction in physiology when she was in medical school. And in her working to get into medical school, she received a scholarship for all 5 years and was ranked as 39th in the pre-medical competitions in India, leading to her entering medical school. She has numerous peer-reviewed articles and one book chapter, and we're delighted to have her with us this evening. So Dr. Kapoor, if you want to bring your slides up, it will knock mine off, and we're so happy to have you. Thanks so much.
Okay, good evening, everyone, and thank you, Dr. Moore, for that very kind introduction and for the invitation to speak. Here is an overview of the talk for tonight. I will be starting with an introduction to venous thromboembolism, or VTE, followed by a detailed management.
Dr. Kapoor, we're not seeing your slides. I don't know.
Okay, let me see.
Okay, they're coming up now.
Yeah.
Coming up now? Okay.
Yeah, just go to presentation mode. Right there, yeah.
Okay, sorry about that.
No problem.
I hope everyone is seeing the overview slide here. So just as an outline, I'll be talking about starting with an introduction to venous thromboembolism, or VTE, followed by details around the management of VTE, with an emphasis on anticoagulation, but also role of other interventions. I will then talk about available anticoagulants, briefly about novel therapies on the horizon, and then finally I will conclude with a section on perioperative use of chronic anticoagulation therapy. Please feel free to ask questions along the way, as Dr. Moore said, or definitely at the end. So thrombosis is a significant problem because it affects a large number of people worldwide, and up to 900,000 people in the United States are affected by VTE, that is deep vein thrombosis, DVT, or pulmonary embolism, PE, each year, amounting to about 1 to 2 people per 1,000 persons per year. Besides, thrombosis also imposes a significant burden in terms of healthcare costs, costing the United States up to $10 billion each year, and up to $15,000 to $20,000 per patient with VTE. Besides the healthcare cost-related burden, thrombosis additionally and more importantly also imposes significant mortality, with 100,000 people dying each year of VTE. And in fact, 1 of 4 people with PE dying or presenting with sudden death without warning. Finally, thrombosis also results in significant morbidity or long-term complications. About 20 to 50% of patients with DVT, experience symptoms of post-thrombotic syndrome, with 5% of patients experiencing very severe manifestations. Also, up to 5% of patients with pulmonary embolism, or PE, experience clinical manifestations and are diagnosed with chronic thromboembolic pulmonary hypertension, or CTEPH, which can be significantly debilitating. So several leading medical societies, including ACCP, American Society of Hematology, hereby I'll refer to as ASH, ISTH, as well as the European Society of Cardiology, has developed guidelines for guidance around the management of VTE, or venous thromboembolism. In this talk, I will highlight and go over the key guidelines and recommendations from the American Society of Hematology ASH 2020 guidelines. There are essentially evidence-based recommendations with an aim to standardize patient care for VTE. Management of VTE for the purpose of this talk and clinically can be divided basically into three different phases. The first phase being the initial management that essentially starts at the time of diagnosis of VTE through about 21 days or 3 weeks after diagnosis. I will then talk about primary treatment of VTE, which essentially involves definitive treatment of the VTE event. It is usually a time-limited phase and is at least usually a period of 3 months. Following this, we'll talk about the third or the last phase, that is secondary prevention of VTE. So first, starting with the initial management of VTE. For this phase of VTE treatment, I would like to cover essentially three key clinical decision-making points. First one being home versus hospital treatment at the time of diagnosis of VTE, followed by choice of anticoagulant therapy, and then finally, whether use of thrombolysis needs to be considered or is indicated. First off, I'll start with the first question that comes up when a patient is diagnosed either in the outpatient setting or in the ER with a VTE event. As for DVT diagnosis, ASH recommends home treatment for uncomplicated DVT, but it does make recommendations for hospital admission and hospital management for those patients who require IV analgesics or those with a concern for limb-threatening DVT. As for pulmonary embolism, the recommendations from ASH are to treat at home for PE that is at low risk of complication. For this, a couple tools that are available to us are the PESI score, or more commonly utilized SPESI score, which stands for Simplified PE Severity Index. While I do not have this tool here, it's available online, and it essentially includes heart rate, blood pressure, oxygen saturation, prior history of cancer for the patient, prior cardiopulmonary disease. And then finally, the recommendation from ASH is for hospital treatment for patients with submassive PE, that is pulmonary embolism without hemodynamic compromise, but with evidence of right heart dysfunction, or of course, massive PE, which is PE presenting with hemodynamic compromise. Now, what about choice of anticoagulant therapy as part of initial management? ASH 2020 guidelines recommend using direct oral anticoagulants, hereby called DOACs, over vitamin K antagonists for treatment of DVT and PE, with the exceptions in the following clinical situations. In patients with a creatinine clearance of less than 30 mils per minute, in those with moderate to severe liver disease, and also those with thrombotic antiphospholipid syndrome. The ASH guideline panel, however, does not recommend one DOAC over another. Now, the recommendations for recommending a DOAC versus over a VKA, a vitamin K antagonist, for the treatment of VTE comes from data that stems from several systematic reviews, several randomized clinical trials, which essentially showed that while there was no significant difference in mortality or occurrence of PE in those treated with vitamin K antagonists as opposed to DOACs, there was a trend towards lower occurrence of DVT, but most importantly, a significant reduction in major bleeding in those who are on DOACs versus those on vitamin K antagonists, with a relative risk, as you can see here, of 0.63. Moreover, it's important to highlight that ASH also acknowledged the fact that DOACs do not require frequent dose modifications, do not require INR monitoring, and do not require dietary restrictions, and is therefore less burdensome to the patients. Moving on to the final question that is encountered in initial management, which is use of thrombolysis versus anticoagulation alone. The American Society of Hematology recommends anticoagulation alone versus thrombolysis in addition to anticoagulation in most patients with a proximal DVT. The exception is for those presenting with limb-threatening DVT, especially in younger patients at lower bleeding risk. However, as for PE, ASH strongly recommends thrombolytic therapy followed by anticoagulation therapy in patients that are presenting with PE with hemodynamic compromise or massive PE. What about submassive PE? ASH recommends anticoagulation therapy alone, as opposed to thrombolytic therapy with patients who have submassive PE or evidence of right ventricular dysfunction at time of presentation with a PE. The exceptions they do state are to consider thrombolysis still in younger patients at lower risk of bleeding that present with submassive PE, or in those with a prior pre-existing cardiopulmonary disease history. Now, before I move on to the next two phases, that is primary treatment of VTE and the secondary prevention phase of VTE, I would like to just briefly go over how we classify VTE events. This classification is based on whether a cause, commonly referred to as a provoking risk factor, is present or is absent. Thereby, VTE events can be clinically classified into provoked VTE by a transient or a chronic persistent risk factor, or as an unprovoked VTE. These terms I'll be commonly using during the course of the presentation from here on. Unprovoked VTE, basically referring to lack of a transient or chronic provoking risk factor. Examples of transient risk factors, and here I have them stratified into major versus minor transient risk factors. Major transient risk factors include major surgery with use of general anesthesia for more than or equal to 30 minutes, or being in a hospital bed for more than or equal to 3 days with an acute illness or C-section, whereas minor transient risk factors include surgery with use of general anesthesia for less than 30 minutes, hospitalization for less than 3 days, estrogen therapy, pregnancy, postpartum period, or being confined to bed in an outpatient setting for more than 3 days, and finally, leg injury with decreased mobility for a period of 3 days. Chronic persistent risk factors, or risk factors that persist even after the development of VTE, include active cancer with or without active cancer therapies, inflammatory bowel disease, autoimmune disorders such as antiphospholipid syndrome, rheumatoid arthritis, SLE, chronic infections, and chronic immobility. Now, moving on to the guidelines from ASH around primary treatment of VTE. This phase again refers to the definitive treatment of the VTE event at hand and usually is a time-limited phase. ASH recommends primary treatment of DVT or PE for a period of 3 to 6 months, regardless of whether the VTE was provoked by a transient risk factor, a chronic persistent risk factor, or was rather unprovoked. However, they do comment and recommend that if the plan is for whatever reason to stop anticoagulation after primary treatment, then for patients who have had an unprovoked VTE or VTE with a chronic persistent risk factor, a longer period of primary treatment, longer than 6 months, should be considered or recommended rather. Now moving on to the next and the final phase of VTE management, which is the secondary prevention. Here it starts after primary treatment of the VTE event is complete, and essentially you're encountering this decision point in the patient's care where you either stop anticoagulation or discontinue the anticoagulant, or continue secondary prevention, which is usually for an indefinite period of time. The decision regarding discontinuation of anticoagulation or continuation of anticoagulation for an indefinite period of time really depends upon an individual's assessment of risk factors at baseline. These risk factors include balancing and closely evaluating the risk factors for recurrent VTE for the individual in question and the risk factors for bleeding. The risk factors for bleeding include, but are not limited to, older age, use of antiplatelet therapy, thrombocytopenia or low platelet count, history of cancer, history of stroke, frequent falls, etc. Now, how I decide whether to continue a certain individual with VTE on long-term versus time-limited anticoagulation is using this triangle approach that was described by Dr. Moll. Here, as you can see at the base of the triangle in red, this reflects the highest risk of recurrent VTE, whereas the tip of the triangle here in green reflects the minimal risk of recurrent VTE. Therefore, as you can see here, unprovoked VTE events in men more than women are associated with the highest risk of recurrence of further clotting in the future, thereby resulting in the recommendation to continue long-term or indefinite anticoagulation if tolerated. On the other hand, at the tip of the triangle here, for patients who had a VTE in the setting of a major transient risk factor, such as a major surgery, the risk of recurrent VTE is minimal, and therefore time-limited anticoagulation for a period of minimum 3 months is recommended. Now, while it is clearer what to recommend in these extreme cases at either ends of the triangle, patients that are in the middle have an intermediate risk of recurrent VTE, and these patients include those who had a VTE due to minor transient risk factors, and also women who had VTE in the context of hormone use. In this middle zone, gray zone, it's recommended to use other tools for risk assessment, such as D-dimer and thrombophilia assessment, looking for strong underlying thrombophilias to guide further decision-making. Moving on to the ASH recommendations in this regard. ASH recommends continued antithrombotic therapy in patients with unprovoked DVT or PE, or DVT-PE with chronic persistent risk factors. For patients who have unprovoked DVT or PE, that is at the bottom of the triangle, ASH recommends against use of prognostic scores. Some of these scores employ D-dimer, and also it recommends against using follow-up ultrasound imaging, looking for residual thrombosis to guide anticoagulation recommendations. Further, for patients with DVT and or PE who have completed primary treatment and you have determined that they do need to receive secondary prevention, the ASH guideline panel suggests using anticoagulant therapies over aspirin alone. For those continuing a direct oral anticoagulant or a DOAC, ASH recommends using either a standard dose or full dose or reduced dose DOAC based on the Amplify Extend studies and Einstein Choice studies that I will very briefly go over in the next slide. For those that continue warfarin for secondary prevention, the recommendation is to continue to target a standard INR goal of 2.0 to 3.0 as opposed to a lower INR goal. So here on this slide, I do have the two studies that I mentioned with respect to reduced dose anticoagulation for secondary prevention of VTE. On the left here are Kaplan-Meier curves showing outcomes from the Einstein choice study, which essentially studied rivaroxaban at two different doses, 20 milligrams and 10 milligrams, as well as aspirin. And as you can see here, on the top left, there was a significant reduction in VTE outcomes in those that were on either dose of rivaroxaban when compared to aspirin 100 milligrams. However, there was no significant risk in major bleeding at about the 1 year mark. Cumulative incidence of major bleeding was about 0.3% in the aspirin group versus 0.4 to 0.5, 0.6% in the two rivaroxaban groups. On the top right here, similarly, the Amplify Extend study showed similar results, wherein apixaban at two different doses, reduced dose of 2.5 milligrams twice a day and a full dose of 5 milligrams twice a day, was compared with placebo for secondary prevention of VTE. And as you can see, again, there was a significant reduction in recurrent VTE and VTE-related deaths in the apixaban groups in comparison to placebo, whereas there was no significant difference here, as you can see at the bottom right, in major or clinically relevant non-major bleeding. So in summary, key takeaways from these recommendations is that for a clearly provoked VTE event, time-limited anticoagulation course is recommended. For an unprovoked VTE, the recommendation is to continue indefinite anticoagulation with an anticoagulant agent versus aspirin, with either full dose or reduced dose DOAC, or warfarin with an INR goal of 2.0 to 3.0. Now, having covered key recommendations and guidelines around anticoagulation management of VTE, I want to take a step back and briefly go over anticoagulant history and how our anticoagulation therapies have evolved over time. The next few slides are particularly geared towards any residents or trainees on the call. So the first anticoagulant was unfractionated heparin that came about in 1916, so over a century ago, followed by the first oral anticoagulant, which was warfarin, that came about in 1939. This was followed by several decades of use of heparin, unfractionated heparin, and warfarin. And then low molecular weight heparin came about in the 1990s, followed by fondaparinux in 2002, and then the DOACs between 2008 to 2014. Most people on the call are probably familiar with the coagulation cascade that I've shown here. This basically includes the extrinsic pathway of anticoagulation here in red, which involves factor 7, activation to factor 7A via tissue factor. And then the intrinsic pathway of coagulation, which is shown here in blue, which involves the coagulation proteins 12, 11, 9, and 8, finally culminating into what's here in yellow, that is the common pathway of coagulation, which results in the production of thrombin and then ultimately a fibrin clot. Now to go over mechanisms of action here, warfarin inhibits factor 7 here in the extrinsic pathway, but also factors 2, 9, 10, as well as the natural anticoagulants, protein C and protein S. The DOACs include oral anti-10A inhibitors, inhibit the factor 10A here in the common pathway, and then the direct thrombin inhibitors inhibit factor 2A or thrombin, again in the common pathway. Now, a helpful way of remembering the mechanisms of action of these drugs lies in the naming pattern, essentially. So agents that target factor 10A have an XA in their names. So here goes apixaban, edoxaban, rivaroxaban, and then the X in fondaparinux. Whereas agents that target factor 2A or thrombin have a BI in their names, bivalirudin, dabigatran, and then the troban in argatroban. Now, with our evolution from in oral anticoagulation from warfarin to DOACs, we've definitely made headway in terms of reduction in bleeding risk. Here shown results from the Einstein and Amplify studies. In the acute phase treatment of VTE events, both rivaroxaban and apixaban showed a significant reduction of major bleeding as compared to the comparator groups that involve low molecular weight heparin and warfarin. However, there is still a bleeding risk that is associated with DOAC use as well that amounts to about 1 to 3% per year when we talk about VTE treatment. And this can deter patients, especially at higher bleeding risk, from using anticoagulation when indicated, or results in suboptimal dosing of anticoagulation. There is an exciting class of agents, namely factor 11A inhibitors, that is aimed to target exactly that, provide safer anticoagulation. Here I want to go over two terms, thrombosis here on the right, which essentially is the development or uncontrolled clot propagation inside of a blood vessel. Whereas hemostasis, which is shown here on the left, is essentially a physiologic process that prevents bleeding by formation of a clot and prevents bleeding extravascularly in the setting of injury, surgery, etc. Now, why factor 11 is being targeted for safer anticoagulation is because factor 11, as we just reviewed a few slides ago, has its place in the intrinsic pathway. Being in the intrinsic pathway, it is indispensable for thrombosis to happen. However, it does not play a major role in the physiological process of hemostasis. Therefore, by means of targeting factor 11, inhibiting factor 11 or factor 11A, the aim is to mitigate thrombosis, but spare hemostasis, resulting in lower bleeding. Just to compare the currently available agents to factor 11A inhibitors, here in vitamin K antagonists, we are ultimately blocking the common pathway of coagulation, thereby resulting in mitigation of thrombosis, but also resulting in hemostasis interruption, resulting in bleeding. Similarly with DOACs, factor 10A and factor 2A from the common pathway or factor 2A from the common pathway are being inhibited, resulting in both thrombosis as well as hemostasis being inhibited. However, as discussed, factor 11 or 11A inhibition results in uncoupling of thrombosis from hemostasis and is therefore expected to decrease bleeding. I would now like to go over recommendations for special populations. As we reviewed, the ASH guidelines recommend using DOACs versus vitamin K antagonists. However, DOACs may not be the answer for certain populations. This includes pregnancy. In pregnancy, the recommended anticoagulation therapies include heparin, unfractionated, and low molecular weight heparin. DOACs and warfarin both are not recommended, are contraindicated in pregnancy. As for breastfeeding, Either low molecular weight heparin or warfarin can be used for therapeutic or preventative anticoagulation. Moving on to cancer. For patients with active cancer, direct oral anticoagulants are recommended. Low molecular weight heparin is also recommended for use in cancer patients. Direct oral anticoagulants are, however, to be used with caution in patients with GI or GU luminal malignancies that are unresected, given risk for GI and GU bleeding. The recommendations are to avoid warfarin in cancer patients. Finally, in patients with thrombotic antiphospholipid syndrome, warfarin remains the gold standard of anticoagulation therapy. Now I would like to cover some special situations or comorbidities that may affect our recommendations around anticoagulation therapies. While warfarin is exclusively cleared by the liver, the other direct oral anticoagulants have a varying degree of renal elimination, with apixaban being cleared 25% by the kidneys, and the most clearance of dabigatran, which is up to 80% of renal elimination. It's important to note that the DOAC studies did not include patients with a creatinine clearance of less than 25 to 30 mils per minute, or those with end-stage renal disease. However, efficacy and safety data of DOACs versus vitamin K antagonists in these populations is evolving. Also important to note that low molecular weight heparin is not recommended for patients with a creatinine clearance of less than 30. For patients with cirrhosis, DOACs are not recommended for patients with Child-Pugh cirrhosis. Finally, talking about obesity. While the initial studies, the phase 3 studies looking at DOACs versus vitamin K antagonists and VTE did not include patients with at the extremes of body weight, with BMIs more than 35 to 40. More recent data, phase 4 studies, including retrospective, prospective studies, and meta-analysis, have shown similar outcomes in patients with BMI of more than 40 or body weight more than 120 kilograms with apixaban and rivaroxaban. However, this data does not exist for dabigatran and edoxaban, and therefore these agents are not recommended for VTE treatment or prevention in patients with a BMI of more than 40 or a body weight of more than 120 kilograms. Now I would like to switch gears and spend some time talking about perioperative anticoagulation management. This is a very commonly encountered clinical scenario given widespread use of anticoagulants in our patient populations. The goal of perioperative anticoagulant management is to minimize procedural bleeding risk and also minimize thromboembolic risk that is specific to a certain individual in question, which is especially increased in the postoperative period. Here on this slide, I have a helpful algorithm or tool from the Anticoagulation Forum, which essentially outlines the approach to perioperative anticoagulation decision-making in 3 steps. When you have a patient that is scheduled for an elective procedure that is taking an anticoagulant and/or antiplatelet agent, the first step is to confirm the procedure that is being planned and then determine the procedural bleeding risk. If the bleeding risk is expected to be minimal, the recommendation is to not interrupt the antithrombotic agent. However, if the bleeding risk associated with the procedure is expected to be low to moderate or high, interruption is recommended. Then moving on to step 2 here in blue. Step 2 involves decisions around timing of anticoagulation interruption. The timing of interruption of the antithrombotic agent depends upon the agent itself, as well as the bleeding risk. being different for DOACs versus heparins versus antiplatelet therapy versus vitamin K antagonists. And then finally, step 3, shown here in red, involves estimation of the patient's thromboembolic risk. The recommendation for patients at low risk of thromboembolism to medium risk of thromboembolism is to not bridge due to high risk of bleeding. Whereas for patients that are at high risk of thromboembolism, but a low to medium risk of bleeding from the procedure itself, bridging is suggested. So to summarize, the first step in approaching perioperative anticoagulation decision-making is to assess the procedural bleeding risk, to determine the need for interruption, whether interruption of the anticoagulant is needed or not. Step 2 involves decisions around timing of anticoagulant interruption, which depends upon the drug in question, procedural bleeding risk, whether the procedure is associated with low to moderate risk versus high bleeding risk, and then finally assessing thromboembolic risk specific to the individual in question to decide whether to bridge or not to bridge. I apologize. Yes.
There's a question in the chat. I'm going to go ahead and read it to you. In your slide, you mentioned that unprovoked DVT-PE should be treated for 3 to 6 months. So what is importance of subclassified unprovoked episode into severe B's less severe risk factors?
I will go back to the guidelines around unprovoked VTE here. But essentially, sorry, this is a lot of clicks. But essentially what I would say is the recommendations around primary treatment of unprovoked VTE is the 3 to 6 months. However, for unprovoked VTE, the recommendation is to really recommend indefinite anticoagulation, which essentially are going into that secondary prevention phase. The patients with unprovoked VTE have a much higher risk of recurrent VTE when they come off anticoagulation, and therefore it is recommended that after primary treatment for 3 to 6 months, they get indefinite period of anticoagulation on that secondary prevention phase, which can be with either standard dose DOACs or reduced dose DOACs or warfarin, excuse me. Does that answer the question?
Dr. Shah, does that answer your question? Yes, yes, it does. Thank you.
Apologize for the clicks. Here. Okay, I wanted to proceed with the perioperative anticoagulation recommendations, and I apologize for how busy this slide is, but I wanted to have this in here as a helpful tool to just have in your pocket when you're encountering these questions about clinical decision making around periprocedural management of anticoagulants. This table essentially outlines the thromboembolic risk, high versus moderate versus low, in patients with mechanical heart valves, atrial fibrillation, or VTE that require anticoagulant therapy. Now, for the purpose of my talk, I will be focusing only on patients with VTE, and I would like to emphasize that patients with at high risk of periprocedural thromboembolism are those that had a VTE event in the last 3 months, especially high risk in patients that had a VTE event in the 1 month prior. Patients with severe thrombophilia, what does that mean? It essentially refers to protein C, protein S, or antithrombin deficiency, or homozygous, that is 2 copies of factor V Leiden or prothrombin gene mutation, or carrying multiple thrombophilias or multiple hypercoagulable states. 2 other high risk for thromboembolism patient Subsets include antiphospholipid antibody syndrome patients and patients with active cancer associated with a high thrombotic risk. Again, a busy slide here, but again, super helpful to determine procedural bleeding risk. I will not go over all these different types of surgeries here, but I really want to highlight that in the top section of this table here, we see high bleeding risk procedures that are associated with a 30-day risk of major bleed more than or equal to 2%. These include major surgeries with a lot of tissue injury involved, cancer surgery, major orthopedic, cardiac, vascular surgery, and I especially want to highlight neurosurgical, neuraxial anesthesia, epidural injections are also in this high bleeding risk category. And then I want to highlight the minimal bleeding risk procedures here at the bottom that have a 30-day risk of major bleed of approximately 0%. These include minor derm procedures such as excision of basal squamous cell skin cancers, pre-malignant cancerous skin lesions, cataract procedures, minor dental procedures including dental extractions, and also pacemaker or cardioverter defibrillator device implantation. So once you've made the determination that anticoagulation needs to be interrupted for your patient in question, next is determination of the timing of anticoagulation interruption. If your patient is on a DOAC and is going to be undergoing a high bleeding risk procedure, the recommendation from the ACCP 2022 guidelines is to hold DOAC at least 48 hours prior to the surgery, then the day of surgery, and then resume regular DOAC dose on postoperative day 2 if there is no major bleeding. On the other hand, the recommendations for patients on DOAC that are planned for low bleeding risk procedures, the recommendation is to hold DOAC for at least 24 hours prior to the surgery, then the day of surgery, and resume regular DOAC dose on postoperative day 1, provided there is no major bleeding. I would like to highlight here that in case of dabigatran, patients who have a creatinine clearance of less than 50 mils per minute need to hold anticoagulation for an additional day in both regardless of high or low bleeding risk procedures. The Anticoagulation Forum provides guidance on a consideration of a step-up approach in patients that are at high risk of thromboembolism. This approach essentially involves consideration of starting prophylactic dose of anticoagulation with either unfractionated heparin, low molecular weight heparin, or a DOAC postoperatively within the first 24 hours until therapeutic or full dose anticoagulation can be safely resumed. The consideration here is to start a low dose or prophylactic dose of one of these agents about 6 to 24 hours postoperatively if tolerated, and then transition to therapeutic dose anticoagulation around 24 hours in case of a low bleeding risk procedure shown here in green, and then at 48 to 72 hours post-procedure in case of a high bleeding risk procedure shown here in red. Now, what about patients that are on warfarin? Patients on warfarin that are planned for a minimal bleed risk procedure, the recommendation is, again, to continue warfarin throughout the perioperative period. However, for patients that are planned for low to moderate bleed risk procedures or high bleed risk procedures, the recommendation is to stop warfarin 5 days prior to the surgery and resume warfarin within 24 hours of the surgery or procedure. What about bridging? For patients that are at low to moderate risk of thromboembolism, the recommendation is to not bridge given high risk of bleeding. However, those at high risk of thromboembolism based on the table that we had outlined for risk assessment before. The recommendation is to consider bridging with low molecular weight heparin starting day -3 from the procedure, with the last dose being given at least 24 hours or 1 day prior to the surgery. What about perioperative management of heparins? In patients who require perioperative heparin bridging and those that are on unfractionated heparin, the recommendation is to stop at least 4 hours prior to the surgery and then resume full dose more than or equal to 24 hours after surgery. For those that are on low molecular weight heparin, the last dose is recommended to be approximately 24 hours a day, a full day prior to surgery, with resumption of low molecular weight heparin at full dose at more than or equal to 24 hours following surgery or procedure, as long as hemostasis is achieved and no major bleeding. Now, while antiplatelet agents are more commonly prescribed by our cardiology and neurology colleagues, I want to briefly mention guidance around perioperative recommendations for antiplatelet therapies. I want to highlight here, again, minor procedures, including dental, derm, ophthalmologic procedures such as cataract surgery. The recommendations are to continue single antiplatelet therapy regardless of high or low cardiovascular risk, whereas for major non-cardiac procedures, patients that are at higher cardiovascular risk are recommended to continue antiplatelet therapy, whereas those at lower cardiovascular risk, the recommendations are to hold antiplatelet therapy. What about timing of antiplatelet interruption? For those that are on aspirin and have been determined to need interruption of antiplatelet therapy, the recommendation is to stop at least 7 days prior to the surgery. For those that are on P2Y12 inhibitors, for example, clopidogrel, the recommendation is to hold for at least 5 days prior to the surgery. Aspirin can be reinitiated post-op around 24-hour mark, whereas the P2Y12 inhibitors can be reinitiated at the 24 to 48-hour mark. Finally, I do want to talk about the role of surgical urgency in decision-making around the perioperative anticoagulation recommendations. This especially applies to patients with VTE who have a high thromboembolic risk. For example, if a patient with VTE who had a VTE event in the last 3 months, especially if in the last 1 month, these patients are at excessively high risk of thromboembolism. If the surgery that is being planned is elective, it is very important to have a multidisciplinary discussion and see if this elective surgery can in fact be delayed if feasible. As for emergent surgery though, if the patient in question is at high thromboembolic risk, especially if they've had a VTE event in the last 1 month, consideration for a retrievable IVC filter should be undertaken. And then, of course, reversal of anticoagulant therapy should be utilized if needed. On this note, I would like to talk about reversal of anticoagulation. Anticoagulation reversal depends upon the strategy employed, depends upon the anticoagulant agent being used. For factor Xa inhibitors, the recommendation is to use andexanet alpha, which is approved for use for anticoagulation reversal in cases of major bleeding or emergent surgery for patients that are on rivaroxaban or apixaban. And this can also be used for patients that are on edoxaban. The dosing of andexanet alpha depends upon the dose of the DOAC in question, whether it's higher dose or the lower dose regimen, and also the time that has elapsed from the last dose of the DOAC. It is recommended to consider activated charcoal for known recent ingestions within the last 2 to 4 hours. However, if andexanet alpha is not available at your center, it is recommended to administer 4-factor PCC at a dose of 25 to 50 units per kilogram for ICH or major bleeding, or 2,000 units IV times 1. For patients that are on dabigatran, the recommendation is to use idarucizumab, which is a monoclonal antibody that binds dabigatran in the event of major bleeding or requiring emergent surgery. Again, consider activated charcoal for known recent ingestions within 2 to 4 hours. However, if this antidote, idarucizumab, is not available at the center, activated PCC or PCC at 50 units per kilo IV times 1 with a maximum of 4,000 units is recommended for anticoagulation reversal. Given the renal clearance of idarucizumab, given the renal clearance of dabigatran, hemodialysis is also an option for patients that are hemodynamically stable. Finally, I would like to share these really nice tools that are available online to help with these perioperative guidance questions about chronic anticoagulation therapy. One of these tools here on the left is a website, Thrombosis Canada, whereas here on the right is this IPRO map app that can also be downloaded on your smartphones that can help with management of anticoagulation in the peri-procedural period. With this, I would like to thank you all for your attention, especially at this hour, and I'm happy to take any additional questions.
Okay, there is a question in the chat that just popped up. It says, how long to continue antithrombolytic therapy post-COVID PE?
Oh, that is a great question. So the question is to how long to continue antithrombotic or anticoagulant therapy post PE, or specifically, I guess the question is about PE. Now, at first, during the COVID pandemic, there were a lot of data coming from across the world about the thrombotic manifestations of COVID. However, what we learned later on the basis of the active trials was that really we were seeing increased risk of VTE in patients that were hospitalized or really sick inpatient or in the ICU with COVID. Whereas the outpatients with COVID being managed in the ambulatory setting weren't really at increased risk of VTE or DVT or PE. Therefore, if somebody has a PE or a DVT for that matter with COVID in the recent 2 months that was ambulatory or mild and managed as an outpatient, that does not actually count as a major provoking risk factor, and we consider that to be minimally provoked or largely unprovoked for the purposes of our recommendations, and I tend to recommend indefinite anticoagulation in those patients. Now, on the other hand, if this patient in question was in fact had COVID with a very severe course, was inpatient, on oxygen, on antiviral therapies, and so on and so forth in the 2 months prior, I would consider that to be a significant risk factor and would therefore probably consider a time-limited, meaning shorter course of anticoagulation in those patients if they did not have any other chronic risk factors that would increase their risk of VTE. So essentially, in summary, it would really depend upon what their COVID clinical course was like. If mild, it does not factor into the decision making. If severe, requiring hospitalization, it certainly is considered a significant provocative risk factor.
I think there's another one in the chat.
All right. Let me see. If a patient has an elevated anticardiolipin IgM, are they at risk for DVT or PE? This 67-year-old patient has 2 autoimmune diseases, including autoimmune thyroiditis and my sorry, myas. I know how to say that. Sorry, myas gravis in remission, but no known CVD. Can you see the chat, Dr. Kapoor?
Let me.
You take your slides down. You can see it. Sorry.
Okay, if I enable this, I just want to make sure that I do not get logged off. Let's see. Okay. If I do stop presenting.
Just click on the chat. It should pop up.
Okay, here. I think I see it now.
One PD from Dr. Dupre.
Okay, if a patient, the question is if a patient has an elevated anticardiolipin IgM, are they at risk for DVT or PE? And the patient in question is an older patient with 2 autoimmune diseases, thyroiditis, myasthenia gravis, but known cardiovascular disease, I think is what is the question. That is a great question. I am assuming that this patient in question has not previously had a DVT or PE, and the question is really about primary prevention, or what their inherent risk of DVT PE is. I would say that an anticardiolipin IgM antibody that is elevated alone in the absence of a thrombotic risk factor, or in case of a woman, for example, pregnancy morbidities, would not alone mean that this patient's risk is increased from DVT or PE. Now, in lupus patients or SLE patients, there is an increased thrombotic risk seen in those patients. But an anticardiolipin IgM antibody, even with this background of 2 autoimmune diseases, would not necessarily automatically mean that this patient is at increased risk, although it's certainly possible that they are. But based on data, I don't have any data to say that they are. Now, if they also had anti-beta 2 glycoprotein antibody that was significantly high, and a lupus anticoagulant that is triple positive antibodies, well, that could change the situation. If they have triple positive antibodies with an autoimmune disease, no history of DVT or PE, I think that is a more compelling clinical scenario for a higher risk of DVT or PE at the outset. But just with that single anticardiolipin IgM, I would say there is no data to suggest that there is.
Are there other questions for Dr. Kapoor while we have her on the call here tonight from anyone on the call? PEs are always haunting things in patients because it's just, unless you actively think about this, it's oftentimes the prophylaxis isn't forthcoming. I know in the renal patients we would see with nephrotic syndrome, they need to be anticoagulated, and it's a huge problem if they have particularly severe nephrotic syndrome. So you have to have them on full prophylactic anticoagulation. Any other questions on any of our callers or our participants tonight? Well, Dr. Kapoor, thank you for doing this. We are very grateful. I love the distinct way you present the material. It's just super. Mary has just sent out the eval form, so they're probably popping up on your emails, and you can go to that QR code that she's showing in the chat now. So my thanks to Dr. Kapoor for an excellent presentation. Also, for each of you that are on the call tonight, thank you for being here. For those of you who are recurrent learners with us, we are flattered you come back and attend our programs. We hope they are effective and beneficial to you. We hope everyone will be with us a week from tonight, the 13th, when Dr. Reimer will be talking about perioperative cardiovascular, not anticoagulation as we did tonight, but cardiovascular management of patients who are in need of a surgical procedure in hospitals. So that announcement has been sent out. You can go to any of the announcements, click on it, and a list of upcoming programs will show to you, and you can register for any of those. So we hope to see you back next week. As I remind our residents, when I am teaching and working with them, please be careful out there. And we hope to see you back real soon. Have a great evening. Good night. Bye-bye.
Bye.
Thanks, Dr. Kapoor.
Thank you all. Have a good night.